Good. Just tell me when you're ready. How are you doing? You all okay? Okay, good. Kia ora mai tātou, ngā mihi te rangi, ngā mihi te whenua, ngā mihi ki koutou, tēnā koutou. Thank you very much for joining me here this morning. I'd like to start first of all by acknowledging my clinical tribe, my clinical colleagues who have been with me here this morning, who have walked and talked with me as we've been through Hutt Hospital, telling me how things are going, how we can do better, and some of the figures and things that they're doing here at Hutt Hospital. So it's a shout out first of all to both the management and to the clinical team, particularly the front line, for everything they have done, are doing and will do going forward. Thank you. Today, what I'm wanting to do is to bring forward the document Achieving the Health Targets High-Level Implementation Plans, which provides a further level of detail around how we're going to achieve the 5 health targets. And if I can talk to that very briefly for a moment, what I call a look back and then a look forward. The look back is if we look at any of the 5 targets that we've got here and go to 2017, or any point you want to choose almost, from when we handed over, nearly all of those health targets have deteriorated from then to now. And there's probably a number of reasons for that, certainly 3. The first would be the incoming government in 2017 chose to not focus on health targets. Health targets would not be a focus of their health policy. I'd put that as one reason. The second would be COVID. Clearly, COVID had an impact on health targets and health outcomes. And then the third factor would be the health reforms. That disconnection with the front line has had an impact on the health targets. If we look forward, and that's what this document is about, it's the look forward for what is it we're actually going to do to advance the health targets so that we can get better outcomes for New Zealanders, or as I say in my government policy statement, to have quicker access to timely access to quality health care that improves life expectancy and improves quality of life is our overall ambition. And so what this document does is it gives another layer of detail behind the targets as to how we're going to go about that, what sort of things we're going to do to improve shorter stays in the emergency department, what sort of things we're going to do to improve first specialist assessment, what sort of things we're going to do to improve our elective surgery, to improve our faster cancer treatments, and to improve immunisations. What we do now, our baseline for these targets is 1 July. And so this first quarter, in fact it's about 10 weeks here now, has been during the busy winter months when we've had the COVID peak as well. So as we see these figures for this first quarter, I expect it to still show what we would normally see during the winter months. But what we have done is established quite a robust framework around targets. We have target champions. We have a daily, weekly reporting around targets. So started to bring up really robust frameworks as to how we monitor targets, who does what, who's got the lead, what are the initiatives, what things need to be done from an infrastructure perspective, what is a policy perspective, what is a people perspective, there's people parts and policy, what parts of that are necessary to advance all of the targets. And what you're seeing in this document here is a walkthrough of some of those high-level implementation plans for how we might look to improve the targets. I think it's self-evident what's in the document, so I don't intend to go over it piece by piece, but it will give you some sense that a lot of work has gone into this and the direction of travel that we're going to have with targets. And so with that, I'm happy to start taking questions.
Minister, how does...
Just to the side.
We could actually leave it. No, yeah, let's leave it, because all the mics are set up. Sorry, mate.
Okay, boss.
Yeah.
Sorry, go ahead. Sorry.
I'm just wondering how general practice factors into this. We've heard that a number of general practices are actually closing, and we know that there is that connection with the emergency department.
Sure. So a couple of things there. Undoubtedly, when we don't have a good primary care sector, particularly an after-hours care sector, we have people turn up to ED who might otherwise be better served by primary care. That is true. It's not quite as much as we might expect. It's not quite as self-evident. There's a number of academic papers that show that actually the number of people who turn up at emergency departments, certainly a proportion of them are suitable for primary care, but a number are there just because their acuity is so high, they do need to be in an emergency department. However, at the end of the day, improving primary care will improve almost all of these targets actually. Certainly shorter stays in emergency department. We can imagine if there's better primary care that maybe a person can be better managed in the community while they're waiting for their elective surgery. Immunisations are the most obvious primary care target. So primary care has a role to play in all of these. I think the next step for primary care as it relates to urgent after-hours care is for the urgent after-hours review, which is due at the end of the year, I think phase 2, to come forward and lay another platform, a national platform, as to what we need to do and how primary care can interface with urgent care and therefore with our emergency departments.
And just in terms of the community infusion centres, do you know how long something like that could take to establish?
So that's really interesting. Very encouraged by the Wairoa and Whanganui community infusion centres. That ability to have, so you have your first or second cycles done in a full-blown infusion centre, because that's where you're going to get complications. But then once it's clear that yes, there's going to be no unexpected events with your particular infusion cycle, that you can then have that closer to the community. Look, that is something that is likely to take a number of months. If we look back at how long it took for Wairoa and Whanganui to get up, it didn't happen overnight. But that is a real opportunity. And I've said to aged residential care, for example, some of the big aged residential care providers, like Lady Knox, which I opened in Epsom, a whole wing, and I said to them, you've got a 24/7 GP cover, haven't you? You could be an infusion centre. They said, we would love to. So there's a number of opportunities out there in the community to be chemotherapy infusion centres, and I'm really enthusiastic, as is the oncology environment, to push that care out that far.
So how much is this plan costing?
This will come from baseline. The plan that we have here is fundamentally coming out of baseline.
Well, how does that work when you're talking about expanding the workforce and hiring people and setting up things?
Yeah, correct, that will come from baseline. Remember, we had an uplift this year, the biggest budget uplift ever across 3 budgets, 16.7 billion. And so we have a cost pressure uplift this year as well. And the plan, as it states, will be coming from baseline.
Is the cost cutting limited what you can do in this plan?
No, reprioritisation creates opportunities for what we can do in this plan.
So can we have a figure on that? As per that question, can we have a figure on the cost?
Oh, no, you would need to ask our Health New Zealand for that. But it does sit within baselines.
So how?
Yeah.
So do you
Has it been costed though?
Well, if it sits within baselines, then it's BAU, so it's part of BAU. And so what the costs are for BAU, what we currently do, for example, for elective surgery, that is BAU. It sits in that bucket.
Yeah, I'm just wondering how you can be assured that you'll be able to fund. How you're assured that this.
Yeah, the commissioner has
going to be funded with
the commissioner has assured me that this can be done inside of baseline.
Doesn't
We asked that
outsourcing
question.
more to private though is surely going to cost more? So are you saying that's still within baseline and expanding that private capacity?
That's correct. So we will be using, as we do currently, outsourced providers. And the benefit here is that we have a 3-year appropriation, where previously we did have 2 last time, but previously it's been annual. And so private providers are quite excited by that opportunity to maybe have certainty over time, which helps us get a better deal as well for the people of New Zealand.
Are you able to assure the nurses in the emergency departments that you're willing to invest in staffing? Because that's what all the emergency nurses tell me, that they need more nurses, more investment in the staff there to be safe and to meet these targets that you've set them.
Sure. So a couple of things there. First of all, the signal we sent before Christmas, the security, better security in emergency departments, which then turned into a Budget 24 announcement. So we know that's being rolled out as we speak. And certainly to achieve our SSED target, there will need to be a workforce contribution. What we have done is, by passing that decision making through to the regional deputy chief executives, they're now able to make a much more local decision and much quicker around exactly the sort of thing that you're raising, that ability to staff up where staffing needs to be.
Will you tell them that's a priority for you? Given particularly what's happening in places like Rotorua?
Certainly the targets and all of the things that go with targets are a priority for me.
Are you able to say when regions are going to get their budgets? We're more than 2 months into the financial year.
My understanding is they have them.
They have them?
Correct.
As of today, because yesterday they did not.
My understanding is when I spoke with the commissioners, he passed it to me, was that the budgets have been passed out to the regions. If something has changed from that, I would imagine he would let me know, but that's my understanding.
So do you still stand by your commissioner and saying we don't have a problem with underfunding here, what we have is an overspend?
Yeah, correct. And
where are these areas of wasteful overspending?
Oh, well, as you've heard us say, we've talked about some of the backline services, the back office services, the non-patient impacting services that have substantially increased in recent times, that the Commissioner believes, and I support him, that we can reprioritise and direct them more towards the frontline sort of staff that we were talking about here.
So do we still have an effective employment freeze though?
No, nor have we. There's been new recruitments every single month, and the opportunity through the regional deputy chief executives to recruit more quickly is there today.
Right, so why do we continually hear from frontline staff and departments that they're not able to advertise positions, or that positions have just disappeared, things that were agreed
Okay, so we have
advertised?
Sure. We have to imagine the Deputy Chief Executive, I think, for this hospital started a week ago, so there has to be some time to establish that. But we've set up the framework and the pathway for enhanced recruitment, and now that they have budgets, they'll be able to recruit into that.
Might we see a shift, would you expect, with this budget now being the new budget coming in, of hiring resuming? Because I can tell you most nurses that I speak to feel that they're severely understaffed.
So again, if we look every month, there's been hiring, so it's not like there hasn't been. So hiring will continue, and it will continue into those areas that we need to hire into.
Minister, you want to expand the vaccination workforce. So you're wanting to, who are these going to be, these new vaccinations?
Okay, so a couple of opportunities there. You heard me talk about, and actually to deploy pharmacies to become vaccinators. Plunkett, it sort of eludes me why Plunkett haven't been credentialed to vaccinate. They're a good example.
So midwives, you're saying, should be vaccinated?
And this is where I want to come to as well. So when I was at Nelson Hospital about 3 weeks ago, the midwives there had credentialed themselves and found a really good way to align their maternity booking system with actually the immunisation system, and find a way where they were able to actually vaccinate. And so we had a really good discussion with them. How would that look if we could roll that through the hospital sector? And then the more interesting discussion was, how might we do that for LMCs? And where it actually got to was the cold chain. How could we get midwives out in the community access to cold chain vaccines so that they could be vaccinators as well?
Not adding to their workload, and will they be compensated for these extra tasks?
So one would expect that the remuneration, like we're doing with pharmacy, where they're remunerated at the same rate that general practice is remunerated, those that are outside in the community, one would expect the remuneration would be the same.
So you want to also discharge people 7 days a week. Is there not that ability at the moment?
No.
How often can we discharge people from hospital?
That we should be able to discharge it every day, but for some reasons, which vary from region to region, there is not same day or every day discharge.
So weekends you can't?
Oh no, some hospitals can, some of the smaller hospitals cannot. That's sort of been part of the issue with regional variation. But part of the solution to that is criteria-led discharge, and that's actually been deployed in a number of places, which has been very effective. But discharge 7 days a week is actually really important.
So what's the total increase in bed numbers and theatre numbers?
When, for, where, or how?
What you said here, you're going to increase bed and theatre capacity, so how many more beds?
Oh, that's right. Oh, look, I would need to get you those details, but if we could talk about where we're going to do that. Totara Homaru, for example, is an increase in operating theatres and an increase in bed numbers as well. There's expansion at the county's Manukau Super Clinic. And why I point those two particularly is because they're examples of that really important separation of acute and elective. And what we do there is we get more efficient delivery of elective care if we separate out the two. Not surprisingly, you don't have the crash trolley sort of around at 3 in the morning and 4 and 5, so you get reduced length of stay. It's a more efficient way to do that. What you'll also see in the notes, and it's already being done to some degree, is Burwood looking at potentially, it is for plastics and a few things, but potentially being that split between acute and elective as well. And indeed with some of the discussions I've had the team here today, that concept of could HUT actually be part of the elective work piece, and Wellington became more of the acute, and we were having some of these discussions here this morning.
I see that you've had here an assurance from Lester Levy that these targets will be achieved.
Correct.
What happens if he can't get them across the line? Does his job come into question then?
No, we'll cross that bridge when we get to it. Targets have several attributes. They need to be achievable, they need to be affordable, they need to be ambitious. These are ambitious targets, and what I've said before is that a number of these targets were hard for the previous government. They're going to be hard for me too.
So
that's our reality.
If he didn't
that's nothing that we've discussed around these targets, but it has been made aware to him that it is a high priority, and he absolutely accepts that it is a high priority for him.
Your officials have briefed you in terms of the unintended consequences that can come from the targets and the potential for gaining them. Said that it can be important to report on report progress via ethnicity, socioeconomic status, and location, also routine audits and reviews by the Health Quality and Safety Commission. Are you going to act on all of those recommendations?
Oh, we're well underway with a monitoring framework for gaming. There were 6, I'm not going to read them out here, I could, but you've obviously seen them as well. There were 6 particular suggestions that the Ministry have had as to how we can monitor unexpected consequences up and down the value chain, actually. And we'll take them up, we'll lift them up into a really tight framework. You wouldn't be surprised with some of them, disaggregating some of the data so that you can actually see particular areas that have anomalies rather than just saying, this is New Zealand, well, what part of New Zealand might be problematic.
So will you be reporting on ethnicity then?
We'll be reporting on all the metrics that Health Quality and Safety, Ministry of Health and Health New Zealand, determine are important to take into account any gaming that might occur. If that's the advice they give me, then that's the advice I will take. Yep.
Minister, at Totara Haumaru, your document says there's going to be 120 beds there established, but the Waitemata DHB, their website says 150 beds. So can you reduce that?
No, I would need to take that up as to why that is. I don't have that explanation here. I have visited Totara Haumaru, and it's very impressive, and its ability to pick up and deliver elective care across the whole region. That's part of the promise of Totara Haumaru, actually.
So that's perhaps
Not yet fully staffed.
It may well, no, definitely not a reduction.
Okay.
Yeah.
When you talk about workforce, who are you talking about expanding to? Are we admin staff as well as doctors and nurses?
Yeah, look, it will be that workforce that helps us achieve our targets. So it could be across the SMOs, likely to be RMOs, it's likely to be amongst nurses, and there is likely, there's clearly some back office staff, booking clerks, etc., that are really important to the targets. So it will depend on where we have the need. There are other needs we have, particularly around nursing and critical care, mental health, maternity, for example. So we're going to need to recruit into them as well.
And just on Rotorua, I'm aware that nurses and doctors there tell me they did raise concerns of understaffing with you at that ED. Should you have done more?
I took this up with the Commissioner and raised it with my officials. Said I had a really excellent visit at Rotorua. They are a high-performing ED, by the way. There are some challenges there. They've raised with me challenges around SMOs. Can you explore how that works?
Have you a message for the, given what you say that there hasn't been, hiring has continued, and yet we've got 148 nursing graduates from the mid-year who can't find work at Whakatau Health New Zealand, which is the highest, for a very long time and unusual. What would your message be to them?
Oh, my message to them would be that Health New Zealand, I have indicated to Health New Zealand that they are a very high priority, and what that means is they're doing a number of things. First of all, through the ACE matching program, they're expanding the number of options that a nurse can make. For example, I believe it may be around 3, the number of choices that they can make. I understand every year a certain number excuse me, a certain number go into the talent pool every year, and a certain number will here as well. So we're making our way really aggressively so that those new graduates can be placed, and also anticipating the 1,700 to 1,800 that will come out at the end of the year. Really important that we've got a pathway. We know this number. Actually, we've known it for 3-4 years. So when we know that number, we know when they're coming out, let's plan and prepare. And that will be across a range of things. What part of that graduate pool is suitable or applicable to primary care? What part sits inside Health New Zealand? Yeah, a lot of work going on with that, actually.
Trying to match the needs in a way.
No, I need to place those graduates. They need to qualify. They're our own culturally competent, domestically trained pipeline. They need to have a pathway to graduation and completion. Yeah.
Just some questions from a colleague. Yes. Sorry, you go.
Just a question on another health topic quickly. There was a report in the ODT that several medical students at Otago University have been caught acting inappropriately.
Yeah, I saw the headline to that. I haven't seen I haven't had a briefing on that, so I'm unable to comment on that.
It's quite concerning, though, isn't it?
Yeah, I haven't been briefed on that, but I did see the headline. Yeah.
Just some questions from General Manager, Minister. Why have you changed the goalposts on alert codes for EDs?
Because they were only applied, I believe, in 2, if I'm correct, 2 EDs, and we want to reduce regional variation. And so we want a consistent emergency pathway, a consistent notification pathway, way across the whole system. So I don't believe that's new. I believe it was in Perth anyway, and it was only 2. I think it was Auckland and Whangarei, if I'm correct.
Well, changing what code red means doesn't fix the pressures EDs are under, does it?
What it does is it signals when do we need to escalate, when do we need to look at overflow protocols, when do we need to be doing other things. That's the purpose of a RAG yellow system.
Isn't this why targets don't work? I mean,
Isn't it what? Sorry.
Isn't this why targets don't work? The goalposts become shifted to game them.
No, not at all. What this is actually improving consistency across the sector so that the whole sector has the same sort of threshold for escalation.
Why has it taken 6 months to announce this plan today from when the targets were announced?
Because the baseline was only 10 weeks ago, 1 July.
The targets are already in place, so how did we...
But the baseline for these targets was 1 July. And so we have to imagine that once we'd announced them, we then needed to figure out, okay, what is the implementation plan for them? You'll understand some of the challenges we've had with Health New Zealand and other areas as we've worked our way through. And to bring up things like national champions and understand all that regional variation, that takes time, but not the least of which our baseline started 1 July, 10 weeks ago.
There's a lot of evidence about nationally consistent guidelines and thresholds and tools and communications. Shouldn't that just be normal BAU stuff?
I don't disagree with you.
Why is it in here?
Because it's not. It's not in the sector. And so we're sending that message and actually bedding it in as an implementation plan. Here's what a national clinical network for that model of care might look like. Here's what national acute flow management might look like. So I don't disagree with you. You might expect that that's just what we do everywhere, but we don't.
Minister, how will you meet the need of Māori and Pacific who overrepresent in presenting EDs?
So a number of things here. First of all, I'm well advised from the Holder Māori Advisory Committee who helped me monitor Māori health outcomes and help me monitor these targets as well. So I get good advice from them, firstly. Secondly, from out in the communities through IMPBs, I get good feedback and good advice as to whether their people are being well served. And then thirdly, through some of the metrics that are monitored as well, as to who are the groups who are particularly missing out in these targets. That's well reflected in the data.
These short stay units and discharge lounges, where will they be set up and what's their purpose?
So they generally sit inside a hospital. So if we talk about a discharge lounge or a transit lounge is their other name, they're generally a room, for want of a better word. They're primarily for discharge of inpatients. Some hospitals do discharge from ED to transit lounges, but they're fundamentally, you've had the ward round at 8 in the morning and the rounding team has said you're suitable for discharge, but the house surgeon doesn't get to do your prescription, your discharge prescription, till 3 or 4 in the afternoon because he's got other ward rounds or he has got other ward rounds. Well, you want to get home, the team wants you to get home, so can we free up that bed and take you to a discharge lounge or transit lounge where the house surgeon or the discharging team can then help you from there. And we know that's very effective. And so it's a good example of why don't we do it everywhere. That's part of the implementation plan so we can make discharge lounges and transit lounges ubiquitous across the sector.
ED nurses say that the targets can can be gained and people get stashed in corridors and funny little rooms. How are you going to prevent that?
Yeah, this is the question that Adam was asking as well. Well advised by the ministry to monitor that. Remember, we've seen the gaming in the past,
yes.
So we sort of have some track record of knowledge as to what can be done. Yep. Good monitoring from Ministry of Health New Zealand, and from HQSC. We'll keep an eye on that. Yeah.
I've got a related question. I mean, you talk about gaming, but one of the criticisms of targets in the past has been that they can engender perverse incentives. I mean, nobody would have a problem with any of these targets. They're all laudable. But when you, like, for instance, focus on seeing a specialist for the first time, a cancer patient, that's not the whole picture, is it? It's just one part in their cancer journey, and it focus on these 5 things going to mean that we miss the big picture.
Yeah, it's a really good point. What we know is that if you have one point of target, that other services generally move with them as well, because your point is well made. We don't want to just say the only things we're going to focus on exclusively are these 5. For example, maternity per se isn't in the targets. Yeah, but what it does do is it drags the whole system along. So, for example, like discharge lounges, that would benefit someone in maternity. It brings the whole system along and helps reduce some of the the delays and some of the inefficient mechanisms that we have in the health system. That's what targets help us do, as well as clearly bringing resources and bringing attention. But I do take your point that there are other parts of the system that therefore may not get that same attention, and we're very aware, and I'm very aware of that as well. Yeah.
But so some of the new cancer drugs will be coming online October 1st, of course. Great news for people. How will that play into the faster cancer treatment? Do you think that those things will work together? Is there some sort of synchronicity?
Yeah, I do. If you look at the business rules for the faster cancer treatment target, one of them is when they get their first infusion, first chemotherapy, so that will be picked up by the 31-day faster cancer treatment target.
Or some of the new drugs in infusions?
Sure.
And one more from a colleague, and I'm done. New Zealand's been excluded from major clinical drug trials, according to senior doctors, because we don't have standard care drugs funded here. So why is New Zealand not doing more for standard care drugs?
Oh, I think it's a bigger discussion than just particularly drugs and clinical trials. I've asked for advice on the whole clinical trials infrastructure. Asked for that a while ago and received some information on that. So we need to build up the clinical infrastructure framework in New Zealand before we start dropping things on it, like is it a drug trial or is it this trial or that trial. So I think there's a piece of work there, firstly. Secondly, the question that you're specifically asking around our clinical trials and specific drugs, that has a significant pharmac implication, a MedSafe implication, and potentially research bodies implications as well, all of which on one degree sit outside of my hands. At its fundamental level, I'm looking to build the infrastructure for clinical trials in New Zealand so that we can be more receptive, more welcoming, more part of certainly international trials and potentially at some point domestic trials.
Was it upsetting that many of the drugs we're just funding now are 20 years old?
Look, if clinically the clinicians say that these are drugs that will be effective to someone who has any given condition, then I'll take that.
Can I just return to the budgets? I know we've touched on it quite a bit, but you've said repeatedly that we've seen record investment into this budget. The unions have said, the Association of Salaried Medical Specialists, nzherald, that we've barely kept pace with health inflation, which is running higher than, and your own chief executive in budget order said we were ahead of budget when it came to hiring nurses, and a quick back of the envelope calculation said that alone would have accounted for this overrun. So how does it square that we're going to pay for all this within the existing budget?
Because two things. One, there was a cost pressure uplift, so there was new money in the last budget. And then secondly, as we've said, we'll reprioritise away from areas that do not directly advance our targets and improve patient care as much as what we want to be doing through targets. Yeah.
Well, how do you know then if other areas are suffering?
What's that,
if you're
sorry?
not measuring them, how do you then know if other areas are suffering, such as access to MRI or CT scans, which are already, as we know, terrible?
Oh, I mean, we'll continue to monitor a range of metrics. So it's not like the only 5 things we're going to monitor are these targets. These system-level measures will still be there.
Do you know how large your cancer workforce needs to be?
For in total?
Yeah, to take into account the new drugs and treatments.
Certainly that's been modelled for the 1st October lead-off as to what we're going to need, and indeed the new funding went out the door. Yeah, new funding went out the door. I would have to get back to you, but it's in the order of 4 to 6 med-oncs. I'd have to check on the number of, so there are 3 groups, med-oncs, registered nurses and pharmacists. And I can get that information to you. That's been modelled.
It sounds like single digits.
And this is what the infusion specialist group that was brought up to advise on this. Remember, it's phased out. But my team can certainly get you that information, and the money's already gone out for that.
So a group of physicians have condemned the treaty principles bill. This is another one from a colleague. What are you doing to ensure they've got great concerns for Māori health? So what are you doing to ensure equitable outcomes for Māori and Pacific people, given so many initiatives aimed at improving outcomes? Vulnerable cohorts are being rolled back.
So we have a range of initiatives for Māori health that include devolving Māori health, certainly in the community, out to iwi Māori partnership boards, where they'll have strategic decision making around what their health needs are and how they can achieve those health needs. I'm well advised by the Haora Māori Advisory Committee. The existing frameworks at the moment are Whakamaua and Pai Tū, which stay in place, and then later this year the Māori Health Strategy will come out as well. So across a range of frameworks we're applying ourselves to Māori health. Very good. Thank you very much.
Thank you.
Thank you.